Alright, so here we go. Our first online lesson. Going to go a little less time today than we will the next couple of days with our first PowerPoint because I want you guys who didn't to go ahead and finish the coloring from the last couple of weeks that we were going through. So I'm going to kind of include that in today's half an hour to, they're telling us to do half an hour to 45 minutes. So we're going to go ahead and probably go for about 20 minutes on this, and then the rest of the time you'll go ahead and color. And if you guys have finished coloring, you get off a little easy today. So, alright, we're going to start with the ankle and lower leg. Since we've done the foot, we're moving up the leg a little bit. So let's get started and see how this goes. Alright, so a lot of the anatomy we're going to talk about with the ankle and lower leg, we sort of already talked about when we talked about the foot, but it's all kind of connected, so we're just going to rehash that a little bit. We're going to add in the tibia and the fibula to our bony anatomy. The tibia is medial, or inside the ankle, and the fibula is lateral, or outside on the ankle. We do have ligaments to talk about with the lower leg and the ankle. We have 3 ligaments on the outside of the ankle. And then on the inside, we have the deltoid ligament, and I'll show you those as we get to the anatomy, a picture of that anatomy. And then the muscles we talked about before, we'll just rehash those a little bit. So the anatomy, again, the bony anatomy, we remember the phalanges, metatarsals, and the tarsals, the calcaneus, the heel bone, and then the talus, which sits above the calcaneus. So here we add in the tibia and the fibula. So not too much new stuff bony wise, but just want to kind of make sure we're aware of all that. So when we move into the soft tissue, we have to talk about the ligaments now, where we didn't really talk too much about the ligaments with the foot. So medially we have the deltoid ligament, and you can see there's different portions of it. We're not going to focus in on what they're called, but just going to talk about the whole structure as a whole, called the deltoid ligament. This is inside the foot. And then laterally or outside, we'll talk about our 3 lateral ligaments. So this first one here is the posterior talofibular ligament, or a lot of times we'll call it the PTL, okay, or the PTF. And then the middle ligament is the calcanofib, or the CF. And then the ligament in the front, or the anterior talofib, is the ATF. Not like the ATF with the government, but the ATF with ligaments. So anytime we have something in the back, it's posterior, and the front, it's anterior, so that helps us figure out where that ligament is. And then we can tell that it runs from the talus right here to the fibula right here, so that's where we get talofibular. And then we have the talus in the front here to the fibula, so that's the anterior talofib. And then here, this ligament runs from the calcaneus to the fibula, so we get the calcanofib. So it helps us really know exactly where that ligament is running. And so when we have ankle sprains on the outside, we hurt those ankles, or those ligaments. And we have ankle sprains on the inside, we hurt these ligaments. Kind of a rehash of the muscles, the extensor muscles, the flexor muscles, okay, including the tibialis posterior and the tibialis anterior, which they don't point it out, but it's right there. And also the Achilles tendon is here, but that's the terminating part of the gastroc muscle, which would be up this direction, and the soleus muscle, which is your calf muscle, okay? So those are our muscles of the lower leg and the foot. So when we talk about preventing injuries of the ankle and lower leg, we talk about these several things. So Achilles tendon stretching. We want to make sure that the Achilles tendon and the calf are stretched properly to have proper range of motion at the ankle. The way we and a lot of times that can be an issue with ankle sprains when you don't have full range of motion and you have shortening of that muscle, it gets to be painful, and it can even lead to Achilles tendonitis. So really important to work on that when you have an ankle sprain, to go ahead and stretch that. But even on a regular basis, making sure that muscle is stretched out so you have that full range of motion of the ankle. Strengthening key muscles, okay? If we have strong muscles around the ankle, we help to protect the ligaments of the ankle. Improving neuromuscular control, so when you're on an uneven surface, you can control the movement of the ankle. Choosing appropriate footwear, we've talked about before with the foot. Making sure you have proper support of your foot will also help to have proper support of your ankle, and then proper bracing and taping if needed also. So with Achilles tendon stretching, we're going to make sure we do two separate ways. So I'm sure you've all seen it before. Foot flat in the ground, kind of leaning towards the wall with the knee straight. Will stretch your gastrocnemius muscle, or the biggest muscle of your calf muscle. And then going ahead and bending your knee in that same position will help to stretch your soleus muscle, which is a much smaller muscle. The reason you want to have your knee straight when you're stretching the gastrocnemius muscle is because it's a two-joint muscle. It goes across not only the ankle, but it also goes across the knee. And like any muscle stretching, this has to be routine. It can't be something that's done one and done. You've got to work on it over time. Strength training has to be both dynamic and static. Okay, so dynamic, you want to have strength and stability while you're standing or in a ready position, but also dynamic, you want to be able to have strength through the full range of motion. Neuromuscular control. Maintaining neuromuscular control will prevent ankle injuries by controlling foot and ankle movement when you're going on over uneven surfaces. Footwear helps to reduce injuries in the foot and ankle, having the proper support, and also having the proper shoe for the proper activity. Okay, taping is obviously very helpful. It has to be applied properly, making sure that there's still good blood supply, is not constricting soft tissue. You still have normal biomechanical function, and it doesn't create any other unnecessary problems like blisters or things like that. That's why we use heel and lace pads when we are doing our ankle tape. Braces are also great. I like them so much better because you can tighten them up as you play. With a tape job, after about 15 to 20 minutes, it begins to loosen up and it's less effective. So I usually recommend an ankle brace that not only has straps to it, but also laces up. And both of those things you can tighten up as you go through your activity. This is especially good because we have so many people who not only play a high school sport where an athletic trainer might be available, but then they're playing club sports where they're not always having an athletic trainer, and they still have that support when they're doing those activities away from their athletic trainer. Okay, assessing the ankle joint. So, a lot of times we're asking a lot of the same questions whether it's an ankle, a knee, a shoulder, an elbow, but there's a lot of things that we're going to focus in. Focus in on with the ankle so we can really know exactly what's going on with the ankle and things that are really specific to the ankle. So first thing we want to ask is what trauma or mechanism occurred, okay? I really, really like to know the mechanism. I even like to see it so much better because a lot of times that'll help me figure out what's going on. So what injury mechanisms are we dealing with can lead us directly to what structures have been injured. Was there any noise heard when the injury occurred? A crack, more bony, a snap or a pop, more soft tissue, may be indicative of a tear of soft tissue. What was the duration and intensity of the pain? Is it hurt all the time? What's the intensity? Was it on a scale of 1 to 10? Just trying to, again, kind of just grade this injury, whether it's something that's not significant or maybe more significant. How disabling was it when it occurred? Could the athlete walk away, or was he or she unable to bear weight for a time? So obviously, again, just trying to really kind of grade this thing out so you know exactly what's going on. Has a similar injury occurred before? I like to know that because I know, is this a reoccurrence? Is this something we need to consider, doing some rehabilitation for a longer period of time? Do they know what to expect in this process? Things like that. Was there immediate swelling, or did the swelling occur later on, and where did the swelling occur? So, a lot of times you won't see immediate swelling with an ankle sprain. Some people just don't swell immediately. Some injuries don't swell immediately. So we want to just kind of see when that when that swelling occurred. What past injuries have occurred in this ankle? So ankle sprains tend to be a recurring thing. We want to know if somebody has been spraining their ankle many different times. Is this a first-time ankle sprain? Kind of rule of thumb for first-time ankle sprains is to go ahead and get an x-ray. So we want to make sure that we are aware of those things. Okay, now what are we going to observe? We're going to observe for an obvious deformity, which may tell us there's a fracture there. Sometimes even with a certain amount of swelling, it may look like it's a fracture, so we don't want to be deceived by the deformity, but definitely want to be aware that there is a deformity there. So it's obviously going to involve, are we looking at, we're looking at both ankles and seeing, do they look the same? Okay, so we're looking for bony contours on both ankles. Do they look the same? Is there deviation? Okay, is there any discoloration? Red, black and blue, even kind of a yellowish sometimes can occur. Depending if you're seeing this injury fresh off the field or if it's been a few days, the amount of discoloration is going to be varied. Is there a crepitus or an abnormal sound in the ankle? A lot of times a crepitus will be indicative of a tendinitis. Sounds like the creaking of a door opening. So you're going to be looking for that. Is there heat, swelling, or redness? A lot of times with heat and redness, you're going to be concerned about infection, so you want to know if that's present. Is the athlete in obvious pain? So a lot of times, even if somebody's injured, they may not be noticing them in obvious pain, but you want to see if they are in obvious pain. That kind of gives you an idea where you stand in the severity of the injury. Does the athlete have a normal ankle range of motion? Okay, so even if they're injured, they may have full range of motion, but you want to make sure that you assess that range of motion and see where their limitations may be. And it's going to kind of give you an idea where you stand with this injury. So you're going to see if they were able to walk to you. Okay, were they limping? Were they hopping? What's going on? How they're coming off the field to you, walking in the training room as you see them come towards you. So that's going to kind of give you an idea again of the severity of the injury. Palpation. So again, like we talked about with the foot, we always want to work our way away from the injury and towards it. You want to have your patient have confidence in you, so you don't want to start by pushing right on the injured area, and then they're going to be like, wow, this guy doesn't know what he's talking about. He's hurting me right away. And you also want to make sure you're focusing in on the bony landmarks and the ligament landmarks and the muscular landmarks. And that's why it's really good to know our anatomy as we're going through this. And we're looking for any structural deformities, any swelling or localized tenderness as you're doing this. So you're really focusing in and honing in on where that injury is. Okay, so with the foot, we didn't really talk about specific special tests, but with the ankle and as we move through the other joints, we will talk about specific special tests that help us to test different ligaments or muscle strength or things like that to kind of hone in on where this injury is. So the first thing that really you're going to do is kind of rule out a fracture. So the main test you're going to use for that is the bump or the percussion test. And you can see in this picture, they're tapping on the bottom of the foot, kind of looking for that pain to reverberate up into the leg, into either the fibula here as I'm pointing at, or the tibia on the inside. If there's a fracture there of any severity, that reverberation will cause that fracture site to have pain. Another thing you can also do is, and I don't have this on here, but you can do it's kind of a squeeze test of squeezing the tibia and the fibula together, up on the lower leg. If there's any fracture there, when you're squeezing that and moving the bone, it's going to cause pain at that fracture site, either along either bone. So just kind of 2 tests to kind of help you figure out, is there a fracture? If you're going out on the field, this is a great way to kind of assess right off the bat, is this bad? Do I need to, get them picked up off the field? Can they bear weight on it? Things like that. The next test I would do is the anterior drawer test. If they're complaining of pain on the outside of the foot or the lateral aspect of their foot, and we're worried about those 3 ligaments, the ATF, the CF, and the PTF, if they're injured. So you can see where this clinician is putting one hand on their shin and one hand's kind of cupped around the bottom of their foot and their heel, and they're pushing and pulling. So they're pulling on the bottom and pushing on the top, and basically looking for motion at that ankle joint and pain in that area to see if there's any degree of movement, which could be a sign of something as minor as a 1st-degree ankle sprain, or maybe even something as significant as a 3rd degree, where you have some tearing. The Taylor tilt test, we can use it for both an ankle sprain that's an inversion or a lateral ankle sprain, or an eversion, which is a medial ankle sprain. So you can see here they're just taking the foot and turning it in, looking for pain on the outside. And then if you turn it the opposite way, we'd look for pain on the inside. Again, the amount of movement kind of tells us exactly what's going on. Is it as minor as a 1st degree or severe as a 3rd degree? And we'll talk about the different degrees and how that works as we move into our injuries. All right, so functional examination. This is really good to use, obviously, to kind of assess the injury right off the bat, but really good also at the end of the process to do return to play to make sure they're ready to get back on the field. And this can even be used kind of as we move through the whole process, as they move through each step of the rehabilitation, to kind of see what their progress is. So different things we're going to do is have them walk on their toes, have them walk on their heels, just kind of see if they're able to do that functionally. Hopping on one foot without touching their heel down to the surface. Stop and starting on running. Okay, if you're running at a decent speed and you try to stop, there's obviously going to be motion at the ankle that will hurt if there's an ankle injury. Changing directions rapidly will also cause stress at that ankle joint. And also running figure 8s on all that. Again, you're changing directions and it hurts. All right, so our first injury we're going to talk about is ankle sprains. Okay, ankle sprains are probably the most common injury that we deal with as athletic trainers and physical therapists and doctors. And there's really 2 main types, inversion and eversion, and then we also talk about high ankle sprains also. So when we have an inversion ankle sprain, we're injuring the lateral ligaments. And when we talk about the lateral ligaments, remember we're talking about the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. Again, the ATF, the CF, and the PTF. A lot of times when we're injuring the ATF, it's usually because not only you have an inversion of the ankle, but also plantar flexion. So that's, remember, when our toes kind of point down towards the ground. So it tends to focus in on the more anterior part of the joint. And then when it's more of a straight inversion, you're going to get more of a calcaneofibular or posterior talofibular injury. Eversion ankle sprains are less common. And the reason they are less common is if you take a minute to look back at the anatomy, you notice that the tibia does not extend as far down into the ankle joint as the fibula does, and it allows more motion to come inversion versus eversion. A lot of times with eversion ankle sprains, you may have sort of a have a little bit of an avulsion fracture off the tibia, because the deltoid will pull off of the tibia. And you also may have a contusion that occurs on the deltoid ligament with an inversion ankle sprain as the joint swings in towards the medial malleolus on the inside of the ankle. High ankle sprains usually are a little bit more difficult to deal with and will take more months to heal than weeks. This is a sprain of what we call the interosseous membrane between the tibia and the fibula. And what usually happens is you have more of a dorsiflexion injury, or the toes come up towards the shin, kind of separates that area between the tibia and the fibula and causes that injury. So that's the reason why we tend to have a longer time with this recovery, because anytime you bear weight on your foot, that separation will occur between the tibia and the fibula, and it will cause pain. All right, so signs of injury. We have a grade 1, 2, and 3. So anytime you have a grade 1 injury, there's usually some stretching of the soft tissue, and maybe just a little bit of some of the ligament fiber tear. Really don't have any instability in this case. Grade 2, you have some tearing and separation of the fibers, and then maybe a moderate instability. And then in a grade 3, there's usually a rupture of all the ligamentous fibers, and obviously a gross instability at the joint. All right, so when we're caring for these injuries, definitely is going to be, and as compared to the past, like I said before, we're going to take a little bit more care with these than we used to, but our initial efforts are always towards limiting the amount of swelling, applying a horseshoe with compression in that area to get the swelling out of that, especially with the lateral ankle sprain, out of that ATF area. Definitely a lot of icing about 20 minutes on and off for definitely about the first day, and then sticking to icing it definitely over the first 72 hours that way, and then after that usually only when there's soreness or after activity. You always keep the foot elevated while you're icing to help gravity to get that swelling out of there. You may want to have this athlete on crutches for at least the first 24 hours, maybe longer, and they shouldn't engage in bearing weight until they can handle it without pain. So I think we're going to stop there, about 20 minutes in, and then again, remember you're going to be finishing your anatomy coloring if you haven't, and then I'll post a few questions on Veracross lesson plan for today for you to answer from this PowerPoint. And we'll pick up where we left off tomorrow. See you guys.